My case is a 24 years old circus trapeze artist fell from a height, suffered lumbar vertebral fracture, became paraplegic in 2 years. He has developed an ischial pressure sore and posted for debridement and flap cover. Discuss anesthetic management. Paraplegia definition is damage to the spinal cord below the upper part of the cord, causing paralysis in the lower half of the body. The amount of function loss depends on the level and severity of the injury. It can be complete and incomplete. Complete is total loss of function and incomplete is partial loss of function. Spinal cord injuries can be classified as primary and secondary. Primary is due to direct damage to the spinal cord. Example like malignancy, any hematoma, any vertebral fracture. Secondary injuries are after the initial injury. Pathophysiology, spinal shock. At the time of spinal cord injuries, direct compression of the sympathetic nerves causing severe hypertension and arrhythmias. The spinal shock is characterized by hypotension, severe bradycardia due to mainly vasodilation due to and decreased preload. Intense increase in afterload and may cause disruption of the pulmonary endothelium can all leads to spinal shock. It lasts up to 6 to 8. Autonomic dysreflexia characterized by disordered autonomic response to certain stimuli below the level of lesion. It consists of hypertension, bradycardia, headache, sweating, pallor, Horner syndrome and pupillary changes. Hypertension is severe and paroxysmal. It can lead to intracranial hemorrhage and pulmonary edema and death. Depends on the level of injury and duration of the injury. Autonomic dysreflexia more common in lesions above T6 level, and a higher level of the spinal cord injury, the more severe the autonomic dysreflexia symptoms. Circulating noradrenaline levels decrease acutely after spinal cord injury, and bladder distension is most common trigger. Respiratory changes. Respiratory insufficiency is most common and mainly muscle weakness, that reduction in the respiratory drive and the ventilatory response to the hypercapnia. Expiratory reserve volume is reduced as a result of loss of active respiration. Retention of secretions and atelectasis are more common and V by Q mismatch may occur. Muscles following spinal cord injuries, acetylcholine receptors spread from the motor end plate of the affected muscle fibers, like suxamethonium depolarizing agent is given. Depolarization takes place throughout the whole muscle. It leads to sudden increase in the serum potassium concentrations, and sudden cardiac death can occur intraoperatively. Bone density and mineral loss is significantly reduced below the level of spinal cord injury. Temperature, high spinal cord injuries impairs normal mechanism of thermoregulations. Hypothermia can occur. And below the level of lesions due to vasodilation. Pressure source, decubitus ulcer, pressure source due to immobility, lack of sensation over pressure areas, altered regulation of skin blood flow, muscle atrophy can lead to chronic infection, osteomyelitis, and sepsis. So regular repositioning is important to prevent the pressure source. Hematological and deep vein thrombosis. These patients are more common in anemia. That is normocytic anemia, and the risk of DVT is greatly increased. So prophylaxis of DVT should administered. A genitourinary system, voluntary control of voiding is lost and bladder is areflexic. Retention of urine can occur, and incomplete voiding leads to high intravesicular pressure and vesicouretic reflex. The patients are more common in renal calculi, urinary tract infections, and renal failure most common. And severe hyponatremia due to nocturnal diuresis. It can prevent by intermittent urinary catheterization. In GIT, acute gastroparesis and ileus is common, and gastric empty is delayed, and stress ulceration also common. Anesthetic management, pre-op management. Before surgery, we should assess the spinal cord injury, like sensory level compared with surgical field, complete or incomplete lesion, time since injury, previous any anesthetic history. These patients are more prone for multiple surgeries. They may require standby anesthesia, local anesthesia, or sedation. airway and neck movements, respiratory and the CVS assessment. We can't assess the patient functional capacity of the patient because the patients are more for prolonged immobilization and musculoskeletal system. Any allergies history, any medication histories like baclofen medications and investigations, full blood count, anemia, infection, sepsis we have to rule out, and the renal function test, serum electrolytes, serum sodium is very important, and the liver function test, ECG, chest X-ray is routine investigations. The standby or local anesthesia or minimal sedation may prefer. This local loss of sensation and pain below the T6 level cord injury. So these patients are more prone for painless surgeries. So local anesthesia is useful with a mild sedation is preference for body surface area. And but local anesthesia containing adrenaline solution should avoid it because there's greater sensitivity to catecholamines. And venous access is maybe difficult due to muscle wasting. General anesthesia. In this case, I can go for general anesthesia. So my anesthesia concerns are neurology concerns, prolonged immobilization, prone position, sepsis management, temperature management, fluid management, sir. Preparation, pre-medication is not commonly used and fasting should be adequate. Anti-aspiration prophylaxis should be given due to delayed gastric emptying. To prevent autonomic dysreflexia, oral nifedipine 10 mg 1 hour before surgery and DVT prophylaxis should continue. Methylprednisolone is administered to reduce spinal cord edema. Antibiotics should ensure in the higher antibiotics. Monitoring, routine ASA1 monitoring applied before induction.
Go ahead.
Yes, sir. Induction with propofol may prefer, sir, because spinal cord injured patient has lower blood volume and it improves distribution. Avoid depolarizing agent like saxamethodium. Prefer non-depolarizing agent. May be difficult in those patients because of used cervical or something, and bradycardia can occur. It can be prevented by the prior administration of atropine. Maintenance with air and CO fluorine. Positioning very is prone position, so adequate padding should be kept all pressure points area. And fluid management, fluid preloading may help to prevent hypotension during anesthesia due to decreased blood volume. These patients are have 60 ml per kg volume, sir. Urinary catheterization should be done to monitor urine output. Thermoregulation. These patients are more prone for hypothermia, so we should maintain body temperature, matters and fluid bombers, hot air blankets, all should be kept and monitored. Post-op care, repositioning the patient, and this is for flap cover. The patient might need maintain to the prone position in the post-op. And adequate nutritional support with continue rehabilitation treatment post-operatively, sir. Thank you, sir.
Very good. Okay. So this is a very rare case scenario, not commonly seen by many, unless you are attached to a plastic surgery department where you can come across this sort of cases quite frequently. Because most of the patients who first get admitted to the neurosurgery or a neurophysician unit after a spinal cord injury. And once it becomes irreversible, the permanent paraplegia or a quadriplegia, then patients are referred to plastic surgery if they develop a pressure sore because of improper nursing care. A best nursing care for a immobile patient is seen by patient not developing a pressure sore. If a patient, even in our ICU, with 3 days of ventilation, if you are not giving a proper back care, you will see a small sore happening at the gluteal region in many of the patients. All of you would have seen. So a best nursing care should avoid this development of pressure sore by turning the patient every 2 hours diligently, attending to the back, putting a lot of powder and ludicolone and other things, and usage of what type of mattress we use to prevent the pressure sore. air mattress or air blankets they are called. So what is the purpose of that? Any Hindu gods mattresses like that? I used to think of a comparison of
Krishna.
Krishna. Krishna is not lying down all the time. Which god is lying down all the time?
Perumal.
Perumal, Vishnu. Okay. And what is the bed of Vishnu made up of? Adiseshan, the snake. And snake, what will it do? It will have the writhing movement. Probably, I think the airbed was imagination from that Vishnu's bed of Adiseshan. Because the snake will not quietly lie. It will always try to move the slithery movement of the snake. So in the same concept, that is why Vishnu did not develop any pressure sore. Okay, so that may be one of the side tracks that I can think of. Anyway, so the airbed or alpha bed is being used, and proper pressure prevention should be done. But in spite of all the efforts, if the patient develops a ischemic pressure sore, one point you have to mention in your answer is you have to first have a discussion with the surgeon whether he is going to do the surgery in full prone position, or sometimes they may do it in lateral position also. If it is a trochanteric pressure sore, they may like to do it in the lateral position because the trochanter is placed more upward rather than putting them in prone. Whereas ischial, of course, it will require a full prone position. So the discussion with the surgeon and what is the duration of surgery and what is the sensory status of that operative area, whether the patient is totally insensate in that area where he cannot feel any pain. That is the important criteria that has to be assessed before you observe the patient for surgery. If he is totally insensate, he won't require any
Anesthesia.
Only, as you rightly said, some monitored anesthesia care with sedation. But if he has got this history of dysreflexia, what are the features of dysreflexia? How do you diagnose dysreflexia in a patient who is either a quadriplegic or a paraplegic?
Bradycardia, hypertension, bladder bowel distension.
Spontaneous, sudden vascular changes, hemodynamic changes. Okay, that is the pathognomonic feature of it will happen suddenly in a patient who has been in the ward with either paraplegia or quadriplegia. Suddenly the BP will shoot up, the bradycardia will happen, he will have diaphoresis, sweating. The triggering factor is the bladder distension. Okay,
Yes,
that is not a part of the dysreflexive feeling. What triggers the dysreflexia is the inadequate drainage of the bladder. So bladder distension is the triggering factor to cause a hemodynamic change of sudden shoot up of BP followed by the bradycardia because of increase in blood pressure and absence of sympathetic this thing to cause reflex tachycardia and sweating. All this, and patient may complain of intense headache also because of the high BP. So these are the features of dysreflexia. This can be triggered intraoperatively in a patient who is exhibited this in the preoperative phase. So for this, they have described that you can even do the surgery under spinal anesthesia. Intrathecal anesthesia also can be given. Don't worry that the patient is having a paraplegia. It is not contraindicated to give an intrathecal block also. In cases where there is a history of dysreflexia, spinal anesthesia is considered a more suitable anesthesia rather than general anesthesia. So patient who has some sensory recovery, who has features of preoperative dysreflexia, you should prefer to go for spinal anesthesia with a longer acting agent, mainly to prevent this dysreflexia happening intraoperatively, not as a method of analgesia or anesthesia for the surgery. It is mainly to prevent the dysreflexia. So the dysreflexia can happen even under GA. That is the reason why spinal anesthesia has been preferred for this sort of cases if there is a history of dysreflexia in the preoperative phase. Otherwise, all the points that you have described are
Sir,
quite
hypobaric
okay.
we can use also.
Hypo?
Hypobaric spinal anesthesia we can.
Hypobaric spinal anesthesia is not being regularly used nowadays because the level is very difficult to judge in that. Unless you
Right, sir.
correctly position and then try to do that, because here you have to give a reverse Trendelenburg to reduce the level going up, not the the Trendelenburg position to prevent the upward rise in the height of the block. So that is the reason why we can go for our regular hyperbaric from weekend itself. Okay,
Yes, sir.
so I'll just share a presentation on that. The screen visible?